reviewer also on our IJ journal, and sir is governing council member of our NSCSA chapter, and even sir was a national executive member of an Academy of Regional Anesthesia. Sir is a reviewer of Indian Journal of Anesthesia also. Sir was a past organizing secretary of biennial CME 2013 at Nagpur. He's a very much demanding faculty at various conferences at our state and national levels, and has a very much publications in various journals also. Sir done very much good job in his presidency. He did first Best City Branch Public Awareness Award, President Appreciation Awards, Proficiency Awards, uh, and even at national level also he got first best city branch awards, public awareness awards, CULS awards, all are in first category. But, so he did a very wonderful job in his tenure during 2019 to 21. So congratulations, sir, on our ISA City Branch Nanded platform. This was we are conducting with the celebration of our platinum jubilee celebration of our ISA national with our city branch also is celebrating silver jubilee here with this. So this one is the tribute to our part of celebration, we can say. It's now screen is yours, sir. Please do it.
Thank you, Dr. Sachin sir, for kind information and introduction, and best of luck for your Silver Jubilee celebrations. Namaskar. Am I audible?
Yes, sir. Clear.
Yeah. Shall I share my screen?
Yes.
Namaskar. Good evening, everyone. I'm extremely honored to be on this platform today, which was previously graced by many stalwarts from all over India. I must congratulate ISA Nanded City Branch, headed by the President, Dr. Prahlad Kotkar sir, and Honorary Secretary, Dr. Sachin Chandolkar sir, for this Friday evening meet endeavor, which has been going on since long time. Actually, I received a call from Dr. Sachin in early July or maybe late April for the possibility of talk on USG use in Friday meet. It was pleasant surprise for me for obvious reasons, because I wondered why my name should crop up when many well-known speakers are there to speak on this topic of USG. Anyway, I'm here today, and many thanks to ISA Nanded City Branch for this honor. Dr. Sachin suggested me to speak on possibility of USG use, specifically in regional anesthesia in freelance practice. This seems a difficult topic to speak on. I'll try my best to do the justice to this topic with some of my own experiences. Greetings from my city, Nagpur, which is best known for many things. Prominent among these are all these things. My professional career has been influenced by these two stalwarts. I learned my regional anesthesia. I learned regional anesthesia from Dr. Sandeep Diwan. I also called him as my mentor. And my thought process changed when I met Dr. Balavenkat sir. And that influenced my professional practice as well. I have been regular to the Ganga anesthesia GARC Ganga anesthesia course for quite some time now, and during this visit to Coimbatore, I visit Isha Yoga Center, where this bust statue of Adi Yogi is present. Adi Yogi is basically a form of Lord Shiva. He is also called as Trinetradhari or Trilochana, meaning having a third eye. There are multiple stories of third eye of Lord Shiva in Hindu Purana. Third eye famously depicts rage or anger, but it also depicts savior of the universe. There is a legend or a story about this thing that once Shiva was sitting and Parvati, Devi Parvati came from behind and closed his both eyes. This resulted in the complete darkness in the universe, and there was a danger of survival of the universe. So the Lord Brahma scared, and he went to Lord Shiva for the safety of the universe, and asked Shiva to open his eyes. But as everyone knows, nobody has a gut or daring to ask his wife to do what she is doing. So he opened his third eye, and that caused a light or brightness in the universe and saved the universe. So third eye is also a savior of the universe. Ayurveda, or say our ancient literature, depicts that there are 7 energy centers in the body, and out of which 6th center is the third eye. It's called as third eye chakra or third eye energy center. Basically, this third eye center said that it corresponds to the pineal gland. It is located between the eyes in the center of the head, and that is linked to the perception, sixth sense, intuition, telepathy, or same pinch thinking, meaning that there is vision in the future, something vision in the future which can be seen, or we can call it as Divya Drushti. So what is the relevance of this Divya Drushti or savior or third eye as far as anesthesiologist is concerned? If anesthesiologist gets something like third eye, which has a Divya Drushti or a savior, which can be a savior to the anesthesiologist in the difficult situations, then nothing like that. And I called ultrasonography as third eye for the anesthesiologist. So the question arises, should an anesthesiologist be using the ultrasonography machine? My answer is yes, of course, he should be using, because it is the future. It is part of postgraduate curriculum now. So the newer generation is learning it in their MD curriculum. So they'll come, and in the near future, this ultrasonography will be the future, the thing in the all the operation theaters and in the armamentarium of the anesthesiologist. It's an objective method. Whenever we are doing interventions, it's an objective method, and seeing is believing. So when we do interventions, it will have a higher success. Definitely, it has a higher success rate. And because we see the structures, it has lesser complication rate. This is now the era of ultrasound guided regional anesthesia or point of care ultrasound techniques. So ultrasound is being used for the invasive lines and pain blocks, and our colleagues in cardiac OT, they they are already using transesophageal echocardiography. So we are already in the use of ultrasound. So because it is a future, we should always go for USG use. So there are advantages. There are advantages of ultrasound in regional anesthesia. There is real-time ability to visualize neural structures, needle tip environments, and local anesthetic spread with decreased possibility of nerve damage due to intraneural drug injection in the nerve. Because we see that the drug spread, we use lesser volume, so dose-dependent local anesthetic toxicity is reduced. So whenever there is inadequate effect, we think that the effect is inadequate, we can use the remaining dose or some more dose, and there is possible repeatability even after drug injection, which is less likely with neural stimulation technique. We see blood vessels around the structures we are targeting. So there is negligible chance of intravascular injection. There is decreased pain from muscular contractions, as we see with nerve stimulation. When there are limb fractures and we do the contractions, and patient can most of the time do have the pain at the fracture site. There is decreased need for rescue analgesia because we are actually targeting the nerve structures, and we are very much sure about the analgesic effect. And if there is any anomalous anatomy, we can also know that, and uh, accordingly do our interventions. So what about freelance practitioners? Should they go for freelance for ultrasound use? Yes, of course, they should start learning. There is no harm in learning any new thing. But the thing is that many times we do learn from YouTube. That is probably, in my opinion, is not right thing to learn. We should learn from the experts, as I learned from Dr. Sandeep Diwan sir. We should do hands-on workshops, not on, and visit the persons, people who are experts, who are doing it regularly, and see what they are doing, and see what could be the pitfalls, learn pitfalls, and how to do those things. We should be learning all those things also. We know the advantages. There are many advantages. Also, the complication chances are rare. So if because there are complication chances are there in freelance practice, we are in hurry. So as there are no complications, so there are delay for the next case is avoided. There are so the person might be thinking, हमें USG कहाँ से मिलेगा, machine कहाँ से मिलेगी? There are many of us are working in various hospitals which are multi-speciality, which are obstetric and gynec setup. These gynecologists, they do have ultrasound machine. ICU setups have ultrasound machines. If the multi-specialty hospital has a cardiac setup as well, cardiologist working over there, they do have ultrasound machines. So we can use those machines as well. Because of predictable, successful, and faster effect, the turnover of the patients are more practically good, and this is very much possible in freelance practice, the use of ultrasound. Now there are few rules and regulations when we are using ultrasound machines. If you want to own it, there are guidelines also. These are already available on this in this article. This is a separate almost half an hour, 1 hour topic to discuss on. So I won't go into details, but the viewers can go in this article and go for that if they are interested. Then there are a few documents when we apply for the registration of the machine or registration of the person doing or registration of the place. Then there are a few documents which need to be produced along with the application forms. This is again can be obtained. This information can be obtained from the PNDT office of the local district where we are practicing, and they are very much helpful in telling us about all these things, what is being needed. But the important thing for us is the copy of the educational qualification we must have, and the copies of the training certificate or experience certificate we must have. For the person who operates, that person's educational qualification and experience certificate is needed. Now, how do we get the experience certificate? How did I get my experience certificate? I attended multiple workshops at various places, hands-on workshops. In the meantime, before that, I went for this all this to know this all the information, and they told me that you need such and such kind of experience certificate or for operating the USG machine. So I attended multiple workshops at 3 monthly or 4 monthly interval in the various cities of India. And later on, I completed my IDRA, Indian Diploma in Regional Anesthesia, and that diploma itself tells that this person is experienced in the ultrasound use. So these are the issues which can be solved. Then there are few hurdles. There are possible hurdles while applying for this ultrasound registration machine as well as personal registration. The first thing, now this has, after the COVID thing, this first point is almost gone. Why anesthesiologist want to register? Anesthesiologist को USG का क्या कर बोल रहे? This was the first question I also got. What is your role in USG? So I had to explain that we do ultrasound guided blocks, we do pain blocks. Then there are multiple uses during the emergency situations as well, point of care thing. So then they got this thing, they information, and later on they agreed. Now after this COVID era, many anesthesiologists, in fact, most of the anesthesiologists, they use ultrasound machine during COVID pandemic, and most of the people now know that anesthesiologists do use USG machine. Then next thing is needed is affidavit of non-obstetric use. That is mandatory for us, because we explain that we will not be doing any obstetric ultrasound. This is affidavit which is required. Then the next thing is we are mobile people. Freelancers are mobile people. So what about mobility of machine? If we buy it, and what is the possibility of mobility? That is not possible. Machine has to stay at one place only. But the thing is, mobility of machine, this part contains two separate things. If we are not buying, and we have a hospital setup where machine is already there, then we need to mention that this machine will be shifted and should be allowed to be shifted to the OT as well. That sentence has to be mentioned in that registration form or registration requirement form when we add our name to that registration thing, machine registration thing. Then there is a learning curve. Once we learn it at various workshops, we learn it at hands-on things. We learn scanning, but there is learning curve for the needling technique as well. So that has to be, this is a possible hurdle. So because of this learning curve thing, few surgeons may not accept. My surgeon is fantastic. He accepts all the newer techniques. I have my own USG machine. I purchased my own USG machine, and that is located at one of the orthopedic center. So he accepts anything I suggest him to. So that is not an issue for me. But there might be few surgeons who may not accept newer technique. फिर इफेक्ट आएगा क्या, कैसे रहेगा? These are all things. He is not, यार ये कर लेना, चल फटाफट भागते. This can be a possibility because of learning. There could be possibility of we might take a slightly longer time for the same procedure, which later on, after expertise, we do within say 2-3 minutes or 5 minutes. So this is if suppose we are in the setup where there is also a radial unit, and if that is busy radial unit, we have to shift the machine from the radial unit. That can be a possible hurdle for our USG practice during freelance thing. Then the cost. Cost of if we want to buy, the machine is definitely expensive. For a better resolution, the good machines, they are costly machines. But something is better than nothing. Whatever machine you have, most of the standalone gynecologists, they have nursing home, they have usually a fairly good resolution machine. So we can do on that machine as well. My opinion or my funda about this cost and buying machine is that if I don't need a luxury car, then I can transfer that amount to buying a USG machine. So I don't have a luxury car, and instead of that, I bought a USG machine for myself. Then the next thing with ultrasound use is record keeping and maintenance. We have to have a display of boards which tells their sex in both English as well as for Maharashtra it is Marathi language. So sex determination is not practiced here, and there should be helpline numbers for the people, and these boards should be displayed at prominent places at the entrance, in the waiting area, and outside the say suppose we are doing in OT, so outside the OT door there should be these boards should be displayed, and of course inside the OT, and we have to keep our registration, MMC registration certificate, USG registration certificate, machine registration certificate, and the this PNDT certificate at the location where our USG machine is being operated. Then we have to maintain a register. We have to maintain register in what thing we have done. So suppose I did today, suppose I did a brachial plexus block. So I have to write the date, name of the patient, age, and the procedure done. And we have to maintain this register at least for 2 years, and preferably for 5 years. Then we have to submit monthly report, which is nil report for us. So by every fifth day of every month. For Nagpur, it is advisable that we should be submitting before the 3rd of every month. So I preferably submit on the 1st of the each month. I personally go and submit the report at the office. There are designated offices for each area, and we have to submit monthly report over there. Then every place which is registered for ultrasound machine and the machine itself has to be re-registered. The registration renewal has to be done every 5 years. These are few hurdles, but we have to do it. If we want to do it, we'll have to do all these things. Then that regional authority, the person that comes for inspection every 3 monthly and sees all the records, notes all the records, and that's all. It comes and sees all the records and takes our sign. Then there is annual maintenance and comprehensive maintenance, MC and CMC of the machine, that has to be considered in the maintenance of all these things. And of course, there can be a surprise infection by flying squad in the hospital. So you might be required to show all your records to them. Now, this is all about record keeping, maintenance, everything. And if we want to buy a machine, or if we want to add our name into the already existing registration of the machine. Now, what are my experiences? My experiences of use of machines. I purchased my machine in the say March 2019 or April 2019 somewhere. So 3.5 years and some 6 to 8 months of COVID era, when the procedures were very less, operative procedures were very less. So say around in 3 years, I did more than 850 total USG guided procedures, of which upper limb blocks were 527, lower limb blocks somewhere around 266, facial plane blocks 30 plus, and others like 40 plus, like shoulder pain block. One of them was decurrent stenosynovitis block, invasive lines, etc. Upper limb blocks include brachial plexus, as we are I learned supraclavicular approach of brachial plexus block by paresthesia technique as a first block in my career, PG days. So most of my blocks are for upper limb are supraclavicular block approach block. They are somewhere around 299. I do almost all of them, supraclavicular, interscalene, axillary, infraclavicular, all of them. Nowadays, recently I have started doing more of infraclavicular blocks. Then superficial cervical plexus block, especially this is being used during the clavicle surgeries. Individual nerves, depending on what kind of surgeries in digits or metacarpals are there. And shoulder pain. Recently, I learned this from Dr. Sandeep Diwan sir during cadaveric workshop of EORA. And next week only I did one of them for lateral jet procedures along with upper trunk of brachial plexus block, shoulder pain and upper trunk block, and had a fantastic effect in the postoperative as well as intraoperative period. Lower limb blocks, my setup is mainly orthopedic setup. So very frequently we do knee arthroplasties. So adductor canal block and catheter insertions is whenever there is, I'm not in hurry This is basically we do after in the post-operative period. So when I am not in hurry, I do this in a leisure time. Then initially when I was very much enthusiastic, I used to do IPAC. But later on found that it takes pretty long time. So I started telling my surgeon that you do it local infiltration yourself during surgery only. But one of this plus one is one of the block I did recently, IPAC, for manipulation of knee under anesthesia along with femoral nerve block with good effect. Then almost all types of blocks in the lower limb as well. This ilioinguinal hypogastric block I did for bone marrow aspiration, which they wanted this, what they call, putting the serum into the joint, and they wanted bone marrow aspiration from that. And with ilioinguinal hypogastric block I did for iliac crest region, and we could manage with that. Then this is Divya Drushti for me. All these things was Divya Drushti. But has this been my savior? This ultrasonography machine has been my savior. Yes, it has been my savior in very difficult situation many a times. But I like to have few cases which I can quote now. Case one was a 62 years male hypertensive diabetic ischemic heart disease with PTCA done, with poor LV systolic function, with ejection fraction of 25%, chronic kidney disease, anemia, hypothyroidism, obese, short neck. I call this kind of patient as Sarvagun Sampanna patient. So this was a Sarvagun Sampanna patient with multiple injections. He was an engineer, was working on the metro rail project of Nagpur. Now this is complete project. So he was working on the metro rail project, and he used to carry his insulin and insulin syringe with him. So he would take he used that same syringe without any cleaning and spirit or antiseptic lotion for many days. And later on, he had injection abscesses, 13 injection abscesses on anterior abdominal wall, upper abdomen, bilaterally, on right arm. Somewhere he was lefty, so he used to prick like this, right arm, and left medial aspects of leg. So he had a history of before that he had history of in-hospital cardiac arrest twice in past, but both the time he was revived. The first time after myocardial infarction, then he underwent emergency PTCA. He was revived. After revival, he went up for emergency PTCA. Then second time in the post-operative period after lap hernia surgery. He was mechanically ventilated during both these episodes. So at this admission, patient said to me that I'm not willing to go for sleep during surgery. I will not be sleeping. I don't want any general anesthesia, and I don't want any kind of sedation. I should be awake during this procedure of incision drainage of all these 13 abscesses. So what was the next? What next? I had only one option of regional anesthesia. So I counseled and informed patient and got informed consent of from him and his family that best thing would be general anesthesia, because there are multiple sites, and this has to be the option for you. Still he disagreed. No, I don't want to go for any kind of sleep now. I want to be awake. I don't want mechanical ventilation henceforth. So how this was initial days of my USG machine, somewhere around July 2019 or thing. There were different sites. 7 abscesses were in abdomen, upper abdomen, 2 abscesses in right upper arm, and 4 abscesses in medial side of leg. So what was my option? I thought, I told him that I'll need to think about this, and I'll come to you after, say, around half an hour. I thought about that and decided that I'll go for bilateral upper cotton tab blocks, saphenous nerve block below knee, and just infiltrate under the upper arm abscesses in the right side. We could manage this. He had some sensation, something is going on, but there was no pain. We could manage this patient with this. And unfortunately, I did not have idea or say this thing to record all these things, and I could not record this thing. Then the case 2 was 90 years male, old inferior wall MI with good, fairly good ejection fraction. He had a vessel disease. Relatives were not willing for CABG since few years. He was on long-term diuretics for swelling all over body and feet. He had frequent hospitalization in cardiology setup. Obviously restricted activity, homebound patient, so say around less than 4 or around 4 minutes of activity, anemic, but his anti-pro BNP was more than 4,000. He was chronically in the cardiac failure stage. Came with fracture of neck femur and required to have bipolar prosthesis. This is a fracture neck femur required to have bipolar prosthesis. My surgeon negatively counseled the relatives that we should not be doing this surgery. Anyway, this is very risky. But relatives were too ready. They were very much ready that anything happens, we are ready to go for it, but do the surgery. The another thing was his spine was very bad. Bad scoliosis, left-sided fracture, this left-sided fracture, bad scoliosis with concavity on the left side. So what was my options? I decided to go for lumbar plexus and sacral plexus block, dual technique, with proper explanation to the surgeon as well as to the patient that if there is no effect today, we'll cancel the case. We'll try it again tomorrow. I did my lumbar plexus dual with Shamrock's technique and with dual mode, PNS as well as USG, and use sacral plexus as well with dual mode. I did not record lumbar plexus, again forgot to record because of actually my recording is done by OT boy. He also helps me during this procedure and records as well. So first time during lumbar plexus thing, I forgot to record this, and then I remembered that I should be recording this thing. So with sacral plexus, we recorded this with dual technique, and we could manage this patient with only left lower limb anesthesia and rest of the things unparalyzed. Case 3 was 59 years female, fracture neck femur, again for bipolar prosthesis, again can say Sarvagun Sampanna patient with severe biventricular dysfunction with grade 3-4 dyspnea, so less than 4 minutes, LV of 20% with LV global hypokinesia and dilated right heart chambers with severe TR and severe PH. Pulmonary artery pressure almost matching the systemic pressure. She had frequent history of CCF with recent episode 1.5 months back. She was on diuretics and digoxin. Obviously, with all these things, she will have renal dysfunction and altered LFT as well because she had a severe TR also. So again, we managed this patient with lumbar plexus block and sacral plexus block. The case 4 was 73 years male, inguinal hernia mesh plasty with old pulmonary TB with destroyed whole of that side of lung, fibrotic lung. So because of that, there was a bad scoliosis of thoracolumbar spine. I attempted spinal anesthesia but failed multiple times. So finally done under ultrasound guided hernia block. So this is how the ultrasound machine has been severe for me. Case 5 was 85 years male. Again, you can say Sarvagun Sampanna, hypertensive diabetic, old inferior wall MI, CVE, multi-drug resistance, old pulmonary tuberculosis, obese with OSA, hypothyroid, could not hear. So giving instructions to him was difficult. He was wheelchair bound because of CVE. He was not able to lie down supine, so he used to sleep propped up and continuously having frequent bouts of cough. This was his X-ray with all very bad left-sided lung. His saturation on room air was 80%, came for fracture tibia, again negatively counseled by surgeon, but patient's relatives were not willing. He was a short and thick neck with stiffness, could not extend. His neck was like semi-flexed. He had a difficult venous access, obese patient with very small veins, 22 gauge intracath by staff, multiple pricks were done and many veins were fired. Again, chronically on cardiac failure with NT-proBNP more than 1,000. So I planned invasive lines, took arterial line and took central venous access in propped up position. Patient was coughing intermittently during the procedure with ultrasound use. When I scanned the internal jugular vein, it was too laterally placed in the neck and it was sitting exactly on the internal carotid artery. So with palpatory method, probably it would have been impossible, I guess, to locate that internal jugular vein. Then this is a recent one. This patient was for left-sided this thing rotator cuff repair, arthroscopic rotator cuff repair, and he had a bad COVID during second COVID wave. So during his recovery period, in one of the CT scan, which used to be done for scoring system, one radiologist told him that your right-sided diaphragm has some problem. That he was knowing. He was also an engineer, and he was knowing he had some right-sided diaphragm issue. So when he came for this thing, he specifically told me that there is some issue with my right-sided diaphragm. I have been told, and I was asked to tell everybody whenever I visit any doctor that my right-sided diaphragm has some problem. So we did as routinely we did an X-ray. It showed an elevated right-sided diaphragm compared to the left-sided diaphragm, and we thought that probably this is hemidiaphragmatic palsy. We sent this patient for ultrasound thorax, and that confirmed that there was absent diaphragmatic movement on right side. This was a left-sided rotator cuff repair, and routinely I do my this thing rotator cuff repair under general anesthesia with interscalary approach of brachial plexus using ultrasound. But because we could make it this thing, we could diagnose in the preoperative period. I use axillary as well as suprascapular nerve block for this instead of this thing interscalary approach using ultrasound, and had excellent postoperative analgesia, and again a severe for me on that day. The ultrasound has been severe for me on that day as well. So these are few cases I wanted to tell that as a freelancer also we can use ultrasound judiciously, and with that help the ultrasound machine becomes a divya drushti as well as severe for us, and learning any new thing is nothing should not be avoided, as being said Bhagavad Gita, which consists of 3 yogas: Jnana Yoga, Bhakti Yoga, and Karma Yoga. And Karma Yoga, it is in the 4th chapter or verse 38 said, Nahi jnane sadrusham pavitra miha vidyate tat swayam yoga samsiddha kalena atmani vindati. So that means that there is no purifier in this world like knowledge. So getting knowledge is always good thing. So one who becomes perfect in yoga, in say the karma yoga, so we are perfect in our anesthesia, but if we get additional knowledge of ultrasound, we find that this is Omaka itself has become we perfect in that yoga as well, ultrasound as well. Thank you very much. I'll stop sharing the screen.
Thank you, sir.
I guess I have justified the topic.
Yes, sir, definitely, sir. Private forum point of view, you did very well, and I'm really appreciate your work, and even all private forum practitioners. You are the what I can say light, or better you can say that you started USG, and in freelancing practice you are using USG. I'm what can I'm say I'm working in NWC and Siemens Corporation hospital, so I know that things what you mentioned in first 2-3 slides. So I wanna mention to all our viewers that these are the documents you should and you must to be know that you have before you going to do USG guided blocks. That is the fascinating things whatever sir has mentioned. But first of all, I want to ask on off of these viewers, sir, you mentioned about that mobilization of USG in OT. One column you mentioned, I never heard because I am also one of the person who goes every 3 months to any USG center because I am also medical officer at Nanded,
Uh,
Waghala, Mahanagarpalika.
during during
Ah, ah.
registration, we have to mention that on which floor this machine will be operating.
Okay,
That is one thing. So that's if the floor OT floor is, we can mention on that. So this machine will be
because
operated in OT as well.
so I'm asking on of ISA Nanded members that most of the couples, I can say freely, that most of the couples or even or practitioner peoples that Jodi is like gynec and ortho most of the time. So gynec people having USG in their OT in that hospital.
In
So
that hospital.
if we add one probe only for our blocks, and if we mention on that thing that we can move this machine into the OT, for them also it will be good for that even PPH the situation or distress situation they also need, or even for MTP purpose also they need sono in OT because that is cleaned product is not or consumption is remained or what you I want to elaborate on that thing only from you uh, uh, just talk on that only how to mobilize the machine from
If
place you to
if
OT.
my machine is always in OT because that is my machine, so that doesn't go on any other floors. But what I information I have, and we do have during even during my working during in corporate setup, that we used to mobilize machine from radiology unit, which was on the ground floor, and our OT was on the fourth floor. For actually for
Yes,
ultrasound guided blocks and TE as well. I was part of cardiac team also, so we would do TE as well. So in that thing, we have to mention in the form itself that this machine will be used at these levels
during registration purpose
during registration
when
only.
you are registering at municipal corporation
Yes, yes,
levels.
yes, yes. At that level only, we have to mention that this machine will be used in ICU, in OT, like that, and in radiology unit. If that machine, that hospital has a radiology unit as well, we have to mention
One
that.
part you mentioned about that thing, I like that thing. Second, I want to ask you a question about every month you are reporting these reporting cases,
Yes.
and this machine is used with OBGYN person or radiologist person, and you are also reporting. How can this happening? Means you are also
when
doing.
OBGY person is reporting that that person has a form F.
Yeah, yeah,
Yeah,
yes, yes, yes.
that and that in they have to report every day
Yes,
before 12 o'clock in the midnight. They have to report
that was
every
that
the
for viewers. I'm explaining
so
this thing to our audience. That is, this is the
so
online method is happening in Maharashtra.
uh,
That every case, whenever you do USG, you have to upload online everything on
so
online.
on
Uh,
that day only they have to
that day
apply.
only. Yes, yes.
In that thing only, and this becomes a Excel sheet in the PNDT office only on
Yes,
your
yes,
name. That becomes
yes,
automatically an Excel sheet in that office.
yes.
So there is a column in this non-obstetric USG.
Okay.
So that automatically gets this thing registered or written or submitted at that level only.
So you
For
do
obstetric, when we have obstetric thing, mine is a my own machine.
non-obstetric thing
So now everything is non-obstetric. So I have to submit it physically every month. I don't have to do
every month.
online. So if that is
Okay.
non-obstetric thing, you don't have to go for online thing. That is all
So
offline.
So for viewers, this one is the very important thing. You don't need to update every case or everything on online point of view. Take thing.
You have a
Uh,
form and you have to just write nil on every
Neil,
column.
yeah.
That is
Yes,
called as
yes,
nil report submission.
yes. So two things happen here. one thing, you can mobilize your USG machine with cooperation with the surgeon. One thing. Second thing, report in front of you. I am explaining to you all. Both things will be cleared now. Third thing, I'm anesthesia point of view. I'm asking as a freelancer. You did this thing, a lot of pain or money you wasted in this thing, and how much I wanna share with all viewers. uh, how much increasing your means money point of view कि भाई ये सीख गए तुम तो कितना मनी अर्न करने लगे, बढ़ गया कि कम हो गया, कॉल्स और ऑल दिस थिंग.
कैसा है कि अब कोई भी कॉम्प्लिकेटेड पेशेंट रहा तो वो मेरे लिए रुकता है. सिंपल सी बात है. मैं इतने सारे कॉम्प्लिकेटेड पेशेंट से मशीन से कर लेता हूँ, तो ऑल कॉम्प्लिकेटेड पेशेंट सर्जन वेट्स फॉर मी. Even if I am freelancer, I am not available on that day. He'll post that patient on the next day when I am available.
Okay.
So automatically there is a gain.
So you learn one thing and increasing the patients, and even your setups also increasing with
Exactly.
this.
Exactly.
So learning is one of the thing you are increasing your practice. I want to share with all viewers also. And Birdy sir did a lot of things in his presidency. He's did very much work in ISA NCB, and he's working a lot in his freelancing practice also. So I take one question. It was in Q&A box. Abhijit Nair, he's my mentor. He's my mentor.
Very good friend of mine. Yeah.
He's my mentor, and I can say, good evening, Saurabh. Sir, wonderful case discussion. Sorry, I joined late. In case you didn't already mention in your presentation, can you narrate your journey with PCP and USG in your experience?
Great. Hi, Abhijit. My journey with PCP and ET. Initially, like I told कि anesthesiologist को क्या जरूरत है मशीन की USG की registration. This was the first question to me. So I explained anesthesiologist को क्यों जरूरत होती है. Then I needed to have experience certificates for which I collected with multiple workshops and IDRA, and that sufficed my criteria of this thing for registration, experience in USG for registration. And later on I explained all those things, what are my experience with USG. I keep all the whatever the required things, legally required things with me for this thing, and I submit my reports monthly. Every 3 monthly there is inspection. The appropriate authority, they come and inspect my premises, and that's all. If everything is clear, nothing can happen to you.
I'm really appreciate your work, Saurabh sir, because I am also one of the inspecting person at Nanded who used to go, or it's my work as an anesthesiologist with USG to see that somebody is doing PCP work, and I'm very much worried about that. You are doing these things in these difficult times where Maharashtra or all over nation is really pointing out that sono-guided things are related to only PCP and DT matters, but not that it's saving humanity, and you are doing that thing. I want to asking on this point of view, but you mentioned that your work is also upgraded and you upgrade with these things, and you are working with different orthopedicians. Mainly you are working with
No, my work is all over except neuro and cardiac and obstetric. My wife is gynecologist, but I'm not her anesthesiologist. so I work.
I'm not capturing you in any what I can say custody point of view, but I'm just asking question private forum point of view, that your work is more towards to ortho.
Major work is orthopedics, but I do my where I have my machine that is mainly orthopedic hospital with some empanelments. So in empanelment, some of the other patients, general surgical patients and other patients, they also do come. So I get chance to have other blocks as well in that setup.
So I want to say to our viewers also in private forum point of view that the decade before Sono, you go to the orthopedician, it was the when you're giving blocks and then that you will pray for the gods. But
Keep it
now that
Ajay.
era, yeah, that era gone.
That
Yeah,
era is gone. That era is definitely
yes,
gone.
yeah, yeah. So you mentioned that okay, that the delay in the complication or saying, or you can delay to the next case also not happening in your case. You did a lot of work in that because what I we are the Marathwada peoples, we are delay at everything's what happening at metros, and our nearest place is metro point of view Nagpur or Hyderabad for our patients also or academic point of view also or Mumbai also. Three things are delay what happened. But you are the first person who is doing freelancing practice in Sono and you are managing that things. That was the best thing. For that purpose only I am calling you on this platform. So Maratha people or other people also learn from you that yes, yeah, I can do this thing and I can manage these things at my level also. But what you mentioned, I'm really appreciate you, sir. Second thing, you did very much good work in ISA, NCB as a president also. Really appreciate you.
Thank you so
I
much.
am taking second question with this note. Dr. Pankaj Gupta, sir, our GC member.
Wow.
Sir, I'm first of all, I'm congratulating you that from Bade sir also, and I'm also, and from all viewers. Sir is asking, Butterfly is a new portable handheld USG machine
Actually,
being
yeah.
launched.
Actually, I don't have any experience with this portable handle. I don't have any experience with portable machines. I have a standalone big machine, my own. So, sorry, sir, Pankaj sir, I don't have any experience.
I can add on this, Pankaj sir. Actually, I'm a municipal person as a medical officer point of view. Actually, I'm studies on that places, but sometimes they give me work for inspection of USG machines. For as an anesthesiologist, I'm telling this thing. Portable machines are not allowed at any places. For that purpose, I'm taking this view that you cannot move any machines from any places. This is the dictum by PCP Act that machine should be placed at that place only. Not portable machines are not allowed at all, and we have to notify that thing. Sir had mentioned that you have to mention on this thing first when you register this case, Sono machine, that first floor, second floor, third floor, this machine will be used.
And on this
So
area, first floor, second
yes,
floor,
yes,
in ICU, in OT, like that. We cannot
yes,
do on a reception. You cannot put
yes, yes,
machine on
yes.
the reception of
So,
that floor.
so, so whenever any pain patient came or any injury patient came and you take your machine or your like ambu bag, you came with UG machine at the entrance. Not like that. UG machine should be kept in that place only. Any authorization should be mentioned to the only. That means when you are giving or taking that buyback or anything, that time you have to mention that भाई हम ले रहे हैं ये मशीन यहाँ पे ये रखेंगे और यहाँ यहाँ यूज करेंगे. Portable machine is not allowed after PCP and Data Act. So butterfly machines are not allowed. I'm on that note. I will take third question from Dr. Sonal Jadhav, our Nanded anesthesiologist member. He used to do regular simulated block. Sir, have registered separately for all machines at different places? Really nice question. I'm asking on this question only.
I did not get this question. That means, does that mean that if I am doing USG at different places, so I need
Yes,
to
yes,
register?
yes,
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 you'll have
yes,
to register for at every place where you're planning to do regional or use USG machine. You'll have to register. Your name
yes,
should be
yes.
on that registration certificate for
Yes,
using that machine.
I will add on this that owner is different. That nursing home can be opened by non-medical also. Like that, UG machine can be taken by anyone. But handler should be radiologist or trainer or MBBS who did in whatever I mean say experience certificate in this whatever sir mentioned that I did training in radiology and blocks and all that. You have to mention in that certificate or to prove that NWCMC or any corporation personal. So that I did any work in USG. Yes, sir.
Yes. And have you registered differently? Actually, I'm doing this ultrasound thing in only one hospital. But if some other hospital gets machine for me, I'll definitely do that for registration for that machine as well. I have my own machine,
So
and
you are
yeah, and
okay. You are
another
the
machine
handler.
with my wife. So I have two machines. On second machine, I usually conduct this. I have my name on that machine, that registration as well, and I usually conduct training programs on that machine.
So one of the thing I will explain to you all viewers that by PCP Act you can only work on two or three sonography only,
That's
not more
correct.
than that.
Yes,
Like radiologists, they can do on three, four, not like that. Like a pathologist, he can work all over Maharashtra. That not happening nowadays. You have to work on two or three, not more than that. You have to mention that I will work with three and with timings. कहीं मैं मॉर्निंग में काम करूंगा, इवनिंग आफ्टरनून में और शाम को. सो ओनली टू और थ्री सोनो यू कैन एज अ हैंडलर आल्सो, नॉट एन ओनर आल्सो, एज अ हैंडलर. So that question, Sonali, really you mentioned that thing. Even in metro or at any places, you have to mention that I am the owner or I am operating person at that machine. Two or three person can operate with, not more than that. That was the act.
that is right.
Fourth,
Yes.
yeah, fourth question from Dr. Sonali Jadhav also. Sir,
Sorry,
have you? Yeah, same,
so
same.
I have registered on two machines. One
Yeah,
is
yeah.
my own, my single name, and another is my wife's name.
So, so guys, this thing is very important. We are the in era of sono guided blocks, but practically, as a private forum point of view, we have a lot of things to learn with this thing that are the very minute things. As a medical officer point of view at corporation levels, we go regularly every 3 months inspection of these machines, and that time we need to almost we are checking that भाई मराठी में लिखा है, इंग्लिश में लिखा है, एप्रॉन पहना है, मशीन बराबर है, उन्होंने वो रजिस्टर मेंटेन किया है नहीं किया है. लॉट ऑफ थिंग्स आर देयर, but still he is doing that work, sonographed blocks, and he's very comfortable with that. And he's mentioning that I did at two or three areas, but there is a what I can say. Uh,
Yeah, only two
uh,
areas. My name is on only two machines at
yeah,
present.
yeah.
And
Yes,
if
yes.
some hospital gets machine for me where I am working, that will be probably the last one.
So we have to fight on that thing also. That as a anesthesiologist, we have to work on different entities with different surgeons and different places. So that will be in coming era. We have to fight with that thing. Maybe we will get that thing. But nowadays, at our places or any other places, that humanitarian ground of point of view, we learn from Bala Venkat sir or Sandeep Diwan sir, even Saurabh Bade sir. We learn or we see things that how many increasing population with that age of the person or size of the person, weight of the person is increasing, complications are increasing. With that, a lot of uh, uh, medical diseases and operating procedures are increasing, and that was the thing you have to tackle. And one of the savior sono guided blocks and sono use, like for intracat to central line blocks to pain management, everything you need USG. And maybe government will really appreciate our work, and they can give us a
Allow
permission to
us. Yes.
yeah, yeah. So before that they can allow us freely. Before that you should learn this thing earliest. I can say on
Earlier
that
the
note.
better, and from the experts. Better
Yes,
from
yes,
the expert, not
yes,
from the YouTube.
yeah. One of the guy from Marathoda, he from that note, as a lighter note, he learned from YouTube and he cracked neat.
Great.
So last question, I think. from Sunita ma'am. Ultrasound is the future of ours. We say it is a stethoscope of pain physicians. I have my own machine and I use
Yes,
it
yes.
for
She
training programs
is
in chronic pain.
presently ISSP president of Nagpur City branch. She does fantastic work with USG as well.
Really, thank you, ma'am. You raised that thing for also even pain management. We need a lot of sono guided blocks and all. Our Varsha Suryanshi ma'am regularly use that thing, that pain management and needling, dry needling things for sono. So really, this thing is I appreciate your work, sir. And this one is the really what I can say that 2-3 points we interact with our viewers and our private forum point of view that sono guided blocks are really a luxury, but with that some crown is there. Like काटेरी मुकुट असतो तो सांभाळावा लागतो आपल्याला आणि त्याच्यासोबत तुम्हाला ते काम करावं लागतं. बडे सर ते करतायत. आमच्या शुभेच्छा आहेत ISA नांदेडकडनं, आमच्या
Thank you.
पूर्ण ब्रँच मेंबर्सकडनं,
आणि
that you are working fantastic job and also you did a very great job as a president also.
Thank you.
Really.
Yes.
So I can so Inka ma'am, you have to any question you raise hands. Can you please unmute yourself if you want to any add-on note or something like that? So three things I want to ask on part of the viewers on in my mind also. Previously, you do blind blocks in your UG or your PG days or
Many years.
before UG, yeah.
4-5 years
But
till I purchased my own PNS.
yeah. So I want to ask on that question only. When Chandrasekhar Cham sir has did one case presentation at Borivali, he mentioned on lower limb with PNS. You regularly use PNS with Sono or only some cases you need PNS?
Deeper blocks I use dual technique, USG and Sono. Superficial blocks I use only Sono. And other setups where I don't have USG machine, I use in all the blocks PNS.
No. I want to mention that that once you learn from Sono, you don't need to PNS. Like that means
when you are enough expertise that you are sure that this block will work, you don't need PNS. But using PNS is always helpful because you actually elicit at the response at lower current, minimal current, say 0.3, 0.4 milliampere. So you elicit your this thing at a lower current, and you can always that can always be helpful. It's not like that it is outdated now with advent of USG. And obviously in deeper blocks like lumbar plexus block and sacral plexus block, you should always be using dual technique.
So guys, don't think like that once you come to USG Gira, that PNS will not go. Our last case meet with Sandeep Diwan sir, he mentioned regularly that PNS is really important thing. You never forget about the boogie whenever you doing BL scopy or anything. Yeah. So we need these both things, scopy with boogies, but less trauma will happen like that. PNS with Sono, surety will be increased or success rate will be increased with
definitely.
that.
When you see the contractions at minimal current, you know that you need, though you're at deeper level, you are not exactly seeing at the tip. You at least know that your tip is near the needle when you are at minimal stimulating currents.
So you are very much happy with what you are doing now.
Definitely, I'm happy. Definitely, my investment is worth doing rather than a luxury car.
Yeah, I really appreciate your work because increasing of the cases will definitely make you
the job
happy.
Satisfaction and the job satisfaction and the appreciation you get from the colleagues.
Really, sir. I'm very much thankful to you on coming on our platform with a busy schedule of you, and that to be on weekends. I'm really happy. with that. But sir, I know add on or any suggestion point of view that what cases you are using PNS with Sono?
Deeper
It's
blocks
already
only.
mentioned only
Deeper
deeper
blocks
blocks.
only. Yeah.
That to be lower limb.
Mainly lower limb. Deeper blocks.
Okay.
Upper limb, they are mainly superficial blocks. So usually I don't need to use it. But if any doubt is there, I'll definitely use that also.
So one thing I want to ask on that thing also. Sono you are using, we are also know about sonography, but what machine you are using, what comfortable zone on which machines you are comfortable with now, or you feel to
Any machine is
explain
okay. Any machine is
okay
okay.
with any.
Once you have fixed sono anatomy, so any machine is okay for this thing. Initial days there was an issue. I could not, because you see what mind knows.
Yeah.
So over a period with experience and with guidance from my mentors, Sundip Diwan sir, and attending different workshops, eventually started to recognize the things which are normal
Yeah.
as well as abnormal.
Yeah, black and white things recognition is very much different thing, that third eye. But you need to identify that thing. You need one separate probe other than surgeons and gynecologists.
We have a linear probe. Our main probe is linear probe, and in
Okay.
few deeper blocks as well as in neuraxial blocks, we need curvilinear probe.
Okay,
So our
that
main
are
work is by linear probe.
okay, that are probes with OBGY
Gynecology.
persons or
Yes.
radiologist.
Same,
They
same,
have with
same, same.
same
The
probe
same probe, curve probe, which gynecologists they do use.
use.
Yes.
Uh.
The same probe is for deeper blocks, and linear probe is
Okay,
different probe. Which
so you don't.
the linear probe is there is always with radiologists. Radiologists have all the probes. Gynecologists have only TVS and curve probe.
Yeah. So with radiology, they have all probes, so no investment. Anesthesia point of view, any you have to buy any separate probe for our blocks
With whom?
for any extra probe buying
If you
happening.
are doing, if your major work is pediatric, probably you might need to have hockey probe, pediatric probe. That is
Okay,
not a routinely available probe. Otherwise,
for adult point of view
routine probes are okay for
with
adults.
radiologist only.
Whatever the probes radiologists do have,
But
those probes
OBGY
are okay.
persons, OBGY
They
persons
have
use.
only curved probes, so you'll need a linear probe as well.
Okay,
You
so
don't have.
you have to buy linear probe with you,
Yes,
or
you'll need to have a linear probe.
so I want to ask on that question only, sir, before concluding this session. If my arthosurgeon having gynec setup with him, and
And he
she is
intends to
having
buy a newer machine, so
no no no
pursue
no
him
no
to
no not on that.
ask him to buy a linear probe as well.
So if she has two probes only,
Then you'll have to buy. Then you'll have to go for additional linear probe.
for single linear probe, how much
Yeah,
it
that
cost?
varies with the company, but somewhere around 1 to 1.5 lakhs. That is the cost
Okay.
for a single probe.
Thank you, sir. Thank you. So, one question I think added on last note with this. Ultrasound is the future by Dr. Sunita ma'am. Sunita ma'am has mentioned that great sort of fantastic lecture. Congratulations.
Thank you,
That was
madam.
the last, yeah, that was the last note thing. So really, I'm an really eye opener session from you as a what I can say third eye person who is using Sono, and we learn a lot from you. Whatever any issue or whatever you are using or you planning in future, please freely contact Dr. Saurabh sir
Sure,
for Sono
I'll
guided.
always be there with you
Yeah, really, sir.
to
So,
help you out.
yeah. Low-caste policy is there in our government, so we are also looking to you. Yeah. Thank you, sir. I'm concluding this session from ISN Nanded City branch. It's our 43 case meet, and we will do 75 case meets till whatever it's my tenure, and we'll do this thing as a platinum jubilee celebration year. So all our private forum point of view case meets, please do join every Friday 8 p.m. Thank you, sir.
Thank you
Thank
very
you.
much. You're doing great
Yeah.
job. ISN Nanded is doing very great job with this Friday
Thank you. Thank you,
tenure.
sir. Yeah. Yeah.
Keep
Thank
it
you, sir.
on. Thank you very much.
Yes, sir.